Welcome to Medicine Grand Rounds. Our speaker today is Dr. Jennifer Meyfeldt, and Jennifer is a faculty member in the Division of General Medicine and a core faculty in our internal medicine residency program, and we are going to miss her deeply. She's leaving us. She and her spouse are moving down south, and she will be deeply missed. Jennifer is going to be presenting today on obesity medicine in internal medicine clinics. And Jennifer, all yours.
Hello, thanks for showing up in person or over Zoom. This topic is very near and dear to my heart because in my internal medicine clinic, since residency, I've been seeing a lot of patients that struggle with obesity. And I've realized that a lot of times we're only treating their chronic medical conditions, but the root cause of a lot of the problems can lie in the obesity. And so it's very rewarding to be able to address that with the patients. Those are my objectives. Let's start with a patient case right away. We have a 41-year-old female patient who presents to her PCP for a routine blood pressure follow-up. She currently takes 10 milligrams of amlodipine. She also takes lisinopril and had to escalate the dose over the past couple of years to 20 milligrams. You notice that her weight has also increased. She now weighs 212 pounds. She's 5 feet 4 inches tall, and her blood pressure today is 136/88 on average. The remainder of her vital signs is normal. Her exam shows predominantly central adiposity, otherwise is normal. So our first question is, what options do we have to diagnose and classify obesity in this patient? The BMI is probably the first thing that comes to mind. It's very straightforward. The weight divided by height squared, very easy to obtain. We measure height and weight in most of our patients in clinic, and it correlates very well with cardiometabolic risk that's been proven in multiple studies. So it's very relevant to us. We can also use it to classify the severity of obesity from class 1 to 3, depending on the exact BMI range. But there are also some cons. It's only an estimate of body adiposity. We all think of this like athletic person, somebody who lifts weight, maybe who has a high BMI, but it's not actually has excess adiposity. And then also maybe people who have volume overload could have a higher BMI, but actually not excess adiposity. And then there's very significant ethnic differences. So let's look at those. Already in 2011, there was a study published in Diabetes Care that looked at the incidence of diabetes in correlation with the BMI, and they looked at different patient populations. And so they basically looked at the white patient population and looked at the BMI of 30, which is the cutoff for class 1 obesity, and looked at what the incidence was for diabetes in that group. And then they compared that incidence to the BMI range in the other groups. And it was obvious that other groups had lower BMI cutoffs, actually. Black patients had a BMI cutoff of 26, Chinese patients 25, and South Asian patients even as low as 24 with the same incidence of diabetes. There's been already some movements there from the WHO, even way before that in 2004, in lowering the cutoff for obesity in those patient groups. And so for the Asian population, they suggest actually a BMI cutoff of 27.5 in their respective national societies, like the Korean Society, the Japanese Society, and the Asian Indian population consensus. They've actually even suggested a lower cutoff of 25. There's also similar movements for Black, Indigenous, and people of color. This is just kind of an overview of different BMIs that were related or correlated with onset of comorbidities, and that was in Mayo Clinic proceedings. And so one interesting finding there was that in Black women, it seemed like the BMI cutoffs were higher, so meaning that potentially that group would tolerate a higher BMI without onset of comorbidities. So that could potentially lead in like providers thinking they don't need to address this as aggressively. But if we're looking at the absolute numbers there, the prevalence of obesity is actually the highest in this group of patients. So we do definitely, from an epidemiological standpoint, need to address it. Followed is the group by the Hispanic patients, and then non-Hispanic Asian patients, or first the white patients and then non-Hispanic Asian patients in terms of the total prevalence. There's other ways of diagnosing obesity that we don't use maybe as often. The waist circumference is a very good measure to screen for excess adiposity in patients with a kind of a borderline BMI of 25 to 35. Again, there's different cutoffs based on whether the patient is of Asian ethnicity or not. And then we can use calipers. Again, very user dependent, obviously, and not something we use in everyday practice. A bioelectrical impedance analysis could be a good investment for an office if they're treating a lot of patients with obesity. So that can be helpful to kind of monitor the body fat percentage over time, especially in a patient that is also doing more exercise and maybe gaining some muscle there. However, that's not very well correlated with cardiometabolic or cardiovascular risk. And then there's more research based ways of diagnosing it with DEXA scan or aeroplethysmography. So let's get back to our patient. We can diagnose her with class 2 obesity based on her BMI of 36. So we don't need to do any further measurement there. Let's go to our next patient, case 2. We have a 48-year-old male patient with no past medical history, presents for his physical. He says he's doing well. He has been struggling for pretty much as long as he can remember, has done numerous fad diets, and only had temporary effect. But then he recently discovered body positivity. Now he feels really good about his appearance and fitness. He's like moving 6,000 steps per day, but he eats 3 large meals. He eats a few snacks and dessert after dinner, and based on a 24-hour dietary recall, he consumes approximately 3,500 calories per day, and his BMI is 40.95. His vital signs are normal. So now we already know that we can diagnose him with class 3 obesity. The question now is, how can we counsel this patient about his metabolic health? And we're getting into a bit of a dilemma there. We have obesity, the disease on one side, and then we have the concept of health at any weight or body positivity on the other side. So we want to be really careful here not to kind of repel the patient in the patient-physician relationship here. So let's look at the complications of obesity. We have the 2 big categories, fat mass disease, which is all the structural and biomechanical complications, and then sick fat disease, which is more the endocrine metabolic problems. For fat mass disease, just kind of a big overview here. It can affect definitely a lot of different systems, but classically we're thinking about things like myalgias, arthralgias, maybe nerve entrapments, and GERD from increased abdominal pressure, things like that. And then the sick fat disease, we are all familiar as internists with those complications. Definitely can affect also lots of different systems. And then one thing to note here, there is a new terminology for hepatosteatosis. We're actually not calling this NAFLD or NASH anymore, but MASLD or MASH, so metabolic dysfunction associated steatotic liver disease, to kind of take out the non-alcoholic part, because a lot of times patients would maybe consume a little bit more than the cutoff for that and would not qualify for studies or medication trials, while still their main reason for their liver disease would be their metabolic underlying obesity and metabolic disease. So we can make or come to a definition of obesity here. So there has to be excessive body fat measured reliably. It is multifactorial. It results in basically a functional impairment, and it results in increased patient morbidity and mortality. In the Obesity Medicine Association algorithm, they call obesity a chronic, relapsing, and treatable disease, which I think is a really good definition to keep in mind when we're managing those patients. So again, back to the question, how do we counsel this patient? Well, we definitely have now a good idea of what obesity, the disease is, so we can definitely figure out if this patient has obesity, the disease. But on the other hand, we still don't know exactly what to do about this concept of body positivity. So weight stigma is a big topic, especially in today's world, and we definitely want to learn more about that. So just last year, there was a synthesis of several studies looking into weight stigma, and there were three main points that patients were reporting: verbal and nonverbal communication. They felt devalued, shamed. Maybe the provider was even disgusted to touch them or similar. And then it impacted the provision of care. They felt that their non-weight related concerns were dismissed, or they felt that they were reduced to just a metric like the BMI. And then that led to systematic barriers to healthcare due to lack of consistency, maybe because they didn't feel comfortable going back to the provider. Lack of proper equipment was driving them not to come back if maybe the blood pressure cuff wasn't right or the chair was uncomfortable. And they felt like they were not getting help to begin with, just outdated advice of just move more, eat less, things like that. So how can we reduce weight stigma? We can use people first language, saying patient affected with or with obesity instead of obese patient. We can avoid hurtful terms. I still see a lot of morbid obesity in the diagnosis or problem list. We should use class 3 obesity, which is the less hurtful term. And then when we document a physical exam, instead of saying obese abdomen or patient is obese, we could say there's central adiposity or things like that. Weight, excess weight, overweight, BMI, we could use those terms instead of other more hurtful ones. And then we want to make sure, like I said, having the appropriate equipment in our office. So now I think we have a better idea of how to find the balance there. So we want to get the patient from the disease part of obesity to health, and maybe just strike out the at any weight, but more focus on the individual weight that's right for this patient and his health. So how do we do that? So let's get into the management part. I think the best approach, and that's the one that the Obesity Medicine Association promotes, is the 5 A's: ask, assess, advise, agree, and assist. And so it always should start with asking the patient if they're ready to discuss their weight or their metabolic health or that their concept of health and weight. And then it goes to kind of assessing causes, complications, readiness to change, advising them on some health behaviors, agreeing on a plan together, and then assisting them in arranging follow-up. And that's kind of what's going to guide the rest of these slides. So for this patient, we can first just ask him if he feels comfortable talking about the concept of body positivity. And he says, sure, but you won't convince me to go on a diet again. Been there, done that. So at least you know now you can talk a little bit more about that. But when you're assessing his readiness now, I think it's pretty clear that he's currently in a pre-contemplative state. He might have been in another stage before when he was going on one of those diets, but currently he's pre-contemplative. And the best way to motivate a patient that's pre-contemplative is by motivational interviewing. So we really want to find a good connection with the patient, try to show them where their values maybe do not align with their current behaviors, and then with autonomy, have them develop their own plan for their health. So I have a little sample conversation here, so I'll just go through this quickly. So you could ask, that's okay, why did you go on a diet in the past? Patient says, I hated feeling self-conscious about my body when I'm out with friends. I also didn't like how tight my clothes would fit. Now I realize I just needed larger clothes and friends that will accept me as I am. You say, I can imagine that the constant worry about your weight and how you look must have been tough. I think it's great that you have come to accept your body as it is and have friends that support you. The patient says, thanks, doc. So you won't tell me to lose weight like my other providers did? He said, I'm not going to tell you what's best for your weight or health because this is something that only you can decide, but I can help you get clarity on what's important to you. Can you tell me what values are most important to you? Patient says, I really love traveling with my husband. We're planning on going to Europe this summer. You say, that's awesome. Which countries are you going to visit? How are your days going to look like? Patient says, we're going to travel to multiple cities, Venice, Florence, Rome. We'll mostly do sightseeing and enjoy the great food. Say, that sounds amazing. Now, has your weight ever impacted your ability to travel, or do you expect that it might on your upcoming trip? Patient says, I knew it. You're trying to get me to lose weight. Well, to be completely honest, I'm not looking forward to squeezing into the tiny airplane seats for 9 hours. And obviously it may be hot in the summer, especially when walking all day. I do tend to sweat easy, and there are not a lot of restaurants with AC in Europe. He say, I understand your concerns about the heat and staying comfortable. Carrying extra weight can put on more strain on your body, especially in hotter climates. Do you think losing weight could improve your ability to enjoy your travels? Patient says, I mean, I'm sure it could, but as I told you before, I've never been able to lose weight, or at least not keep it off. Low carb, low fat, it's just not sustainable. I love food. So then you could say, I hear ya, most popular diets are too restrictive and lead to long-term success. Sounds like you would like to be more comfortable in your body, especially on your travels, which are so important to you, but not at the expense of your pleasure of eating and your positive body image. Is that correct? And the patient says, exactly. So that's just one example of how a conversation could go. But this basically motivates the patient to reflect on their goals, see if maybe weight loss could be a good option for them. So now other things that we need to assess, again, we want to think about a full history. We want to think about a physical exam and some diagnostic tests. So for the history, we want to start with figuring out their weight history, where there are certain triggers. Has obesity affected them since childhood, maybe puberty, childbirth, menopause, or other big life events? Weight management history. Have they done any prior medical supervised treatments, any diets they've tried, any physical activity programs or things like that? We want to assess their nutrition, their activity, their behaviors, especially screening for eating disorders, and then figuring out what their motivation to change is. Again, we've already talked about this. Important to note that also we want to figure out what is the cause of their current obesity, and that's very multifactorial, and we always should keep that in mind. And we should use a trauma-informed approach, which is new in the 2024 Obesity Medicine Association algorithm. So asking what happened to this person instead of what's wrong with this person. Past medical histories, again, we want to assess for those complications. We want to figure out if they have any contraindications to medical weight loss, like pregnancy, untreated eating disorders, severely uncontrolled chronic or obviously terminal illness. And then we want to see if they have any contraindications to medications. So there's multiple medications that would be contraindicated in certain medical conditions. So just keep that in mind. I think we all have now heard about with the GLP-1 agonists that we need to ask about pancreatitis and or medullary thyroid cancer, especially for that, also for the family history. But there's a lot of other medications that could cause interactions. And then substance use disorder as well. For past surgical history, mainly bariatric, other GI tract, cardiovascular, to know what their risk is, for example, for exercise, hormonally changing surgeries or cosmetic surgery. And then otherwise, for medications, we want to look if they have any obesogenic medications. There's a lot of different medication categories that can cause weight gain, but we want to think about the commonly used ones like antidepressants, SSRIs, especially the ones like paroxetine. For anticonvulsants, we want to keep gabapentin in mind because we use it a lot for pain control. And then for diabetes medications, we want to make sure somebody who's maybe on an old regimen with insulin, sulfonylurea, is maybe thinking about switching that to one of the weight negative medications instead. And then also beta blockers, especially metoprolol, propranolol, are very weight positive, and the newer generations less so. And this is a nice overview here with possibly weight positive medications and possible alternatives from the Common Spirit algorithm, actually, of obesity management. And then we want to think about interactions with some of the medications we might use in our treatment. So phentermine could interact with ADHD stimulants, for example. Naltrexone obviously can't use if a patient takes opiates. GLP-1s could have effects on hypoglycemia if they're on other hypoglycemia-inducing medications. Bupropion could mess with someone's antidepressant regimen, and then orlistat can lead to decreased vitamin K absorption. So warfarin, that would be something to think about. Then you want to talk to them about sleep, substance use, and their socioeconomic background in order to know where they're coming from to decide on a good plan together. And then in female patients, their menstrual history, contraception, and desire to become pregnant should be assessed. On physical exam, really just screening for any complications of their obesity, like obstructive sleep apnea, Cushing's disease as like maybe an underlying cause of their obesity, and then looking for any the waist circumference. Again, we've talked about that before, and again, the rest is more so complications like hepatomegaly, hernias. Again, the same for joint problems, assess for any complications there. Acne hirsutism to screen for PCOS, acanthosis nigricans, achondroplasia to screen for insulin resistance, and Then lastly, neurologically, we can potentially find indication or something indicating thyroid disorder by depressed reflexes. Psychiatrically, we want to look for any depressed mood, tearfulness, SI, obviously, if indicated, screening for that to make sure that the patient has no underlying uncontrolled mood disorder. Diagnostic testing, there's a couple tests that we want to get in all patients that we're starting on a weight loss program. So CMP, CBC, hemoglobin A1C, fasting insulin can be more sensitive than that. So that's definitely something to consider. Fasting lipids, TSH, and then in women with childbearing potential, a urine pregnancy test. Special considerations would be for evaluating for Cushing's disease, PCOS, potentially a cardiovascular workup, again, before starting exercise, a sleep study, or further evaluation of elevated transaminases if needed. So let's talk about our third patient. We're going to go through more treatment approaches with them. So this is a 38-year-old non-binary patient, presents to discuss weight loss. They report that their weight gain started in college and was initially slow and steady. 5 years ago, they were diagnosed with bipolar disorder and started on medications for this. They've gained another 60 pounds since. They report being very unhappy about this and want to lose weight. Their main motivation is improving their chronic back pain, which has gotten much worse with the recent weight gain, leading to escalation in the pain regimen. So let's go through the history together. So first, nutrition. They do like a kind of a 24-hour recall. So they report eating a Pop-Tart for breakfast, lunch, kind of a sandwich, some chips, a dessert, kind of like our lunch, our boxed meals here usually. Finally, the largest meal of the day is dinner, composed of some type of boxed or frozen meal that they can make quickly. It's often pasta and pizza. They're very busy and have no energy to make their own food. Sometimes they snack in front of the TV. Activity, they used to go for walks almost every day, but since the back pain has worsened, they're still doing some daily back stretches and gentle yoga 3 times a week, but no more walking. They deny any binging or purging behavior, admit to cravings for pasta and pizza when they try to switch their evening meals to a low-calorie choice before, so they return to their usual habits. They have no relevant past medical history. Social history, they drink 1 to 2 glasses of wine occasionally. They have used cocaine in the past when they were in their 20s, but not in 10 years. And then their sex assigned at birth is female. They report regular periods. They're sexually active with a female partner, and they're not planning to become pregnant in the near future. Medications include the quetiapine, duloxetine, gabapentin, cyclobenzaprine, and then the tramadol that they're taking pretty much daily. Vital signs are normal aside from a blood pressure of 136/82, and the BMI is 42. Physical exam shows central adiposity, limited range of motion in the lumbar spine, otherwise it's normal, PHQ is normal, and then their labs are normal aside from an LDL of 135 and an HDL of 38. How would you counsel this patient and develop a plan to achieve their weight loss goal? So for that, I'd like to go to our third and fourth A here, advise and agree. I like the 4 pillars of obesity treatment that the Obesity Medicine Association uses here: nutrition, physical activity, behavior modification, and medical intervention. And I think that's especially important. We'll talk about medications later, since the new GLP-1 agonists are on the market, and a lot of people see that as kind of a quick fix to weight loss, whereas we really need to focus on approaching this more broadly. So let's start with nutrition. I really love the title of this book. It's actually a good book too, but the title is the best, because oftentimes we ask ourselves, what the heck should I eat? And then we also ask ourselves, what should we tell our patients what they should eat? So this book kind of goes about all the science in nutrition, probably over the past century. And so kind of summarizes some things there. But in general, it's hard to advise a good plan because there's so many different there have been so many different recommendations over the years, whether it's low fat, low carb. So it's really hard, even as a provider, to make good recommendations. But what I think is really important is focusing on a nutritional plan. So as part of like a comprehensive intervention, something that includes small changes towards a goal that the patient can sustain over long term, and not just a diet where we tell the patient, hey, you should do X, Y, Z, or you should eat these foods and not eat those foods, because really a lot of times they consider this as a short-term solution. They do it for some time and then they kind of fall off the wagon and go back to their prior habits. So factors that can influence the success are patient preference and adherence. So like if somebody's eating 500 grams of carbohydrates a day, probably you won't make them adhere to a low carb diet within a couple weeks. There can be an individual metabolic response depending on underlying factors. There can be underlying metabolic conditions that require different treatments. And then they have different nutritional requirements depending on how old they are, whether they're male or female, and other things. The effects of dieting, or the detrimental effects of dieting, were actually showcased in the Biggest Loser study, published in 2016, where they took 14 Biggest Loser competitors of that TV show, and they checked the mean weight loss. After the show, it was around 60 kilograms. And then they looked at the resting metabolic rate, and it had decreased by 600 kilocalories a day. That's like a burger with fries. So after 6 years, they actually looked at the weight again, and those participants on average had regained 41 kilograms. And then they looked at the resting metabolic rate, and the sad thing was that really it didn't correlate, the recovery of the resting metabolic rate didn't correlate with weight regain. So the bottom line here was the resting metabolic rate was still 704 below baseline after those 6 years. And so the bottom line was the resting metabolic range was still suppressed and did not recover with weight regain. So that's really sad to think about if patients go on those numerous diets, and then they end up in a worse spot afterwards than they were in before. So there are different nutrition plans. There's low calorie, low fat, low carb, DASH diet for hypertension, Mediterranean, whole foods, plant-based, and then there's the whole concept of intermittent fasting. And all of these can have some benefits or disadvantages. So again, very individualized approach. So we really have to look at those pros and cons of each and see if a patient would fit into that category. For the intermittent fasting, just one thing to note there was actually no benefit for weight loss as compared to calorie restriction. In addition to calorie restriction, there was some benefit, but if it's just compared with pure calorie restriction, it is not effective or more effective. So what's the best nutritional plan? It's the one that the patient can maintain. There was another study published last year in JAMA Internal Medicine that compared 4 nutritional plans and looked at decrease in mortality, which was actually associated with diet adherence, regardless of the type of diet. So that really means it's more important that the patient can maintain it. And then the Common Spirit Obesity algorithm has some really good kind of take-home messages of things that we can tell our patients. So in general, we want to tell them to limit ultra-processed food, limit energy-dense sweets and beverages, and there's some specific recommendations on added sugar. They should aim for a calorie deficit, get enough protein, adequate fiber, and then limit alcohol, actually to lower than the general alcohol recommendations, because again, it's also calorie dense and can also add to calories that they're consuming. So next pillar here is the physical activity. First of all, the impact on weight loss from physical activity is actually really low. 3.5 pounds of weight loss with regular exercise, which is pretty disappointing. So it's not a really good option to tell the patients just, oh, don't worry about the diet, just move more. That's not going to help. But there's definitely a lot of different health benefits that have been proven in studies to be associated with increased physical activity. So that's definitely something we should still include in our counseling. We should definitely still get the patient in the long term to be more active for those benefits. The general recommendations, we know those 150 minutes per week of moderate physical activity is pretty standard. And then there's another important concept that I like to talk about with my patients is non-exercise activity thermogenesis, or NEAT. And that's really all the exercise that does, or the activity that does not include sleeping, eating, or exercise. So that can be parking your car a little bit further away and walking a little bit longer to the store or wherever you work, or things like that. You could take the stairs instead of the elevator. All that counts into NEAT. And that can make up to 60 to 65% of the days of the day. So that can have a significant effect on energy expenditure too. And then we can add strength, flexibility, balance, depending on patient needs. Now, to agree on a physical activity plan, it's good to use the FIT prescription. So we want to agree on a frequency, intensity, type, time and enjoyment of a physical activity. So that could be a patient is agreeing to go to the gym maybe 3 times a week, moderate activity on the treadmill for 20 minutes each, and they're going to listen to their favorite playlist to enjoy it more. Then the behavioral modifications, that's a very big topic, and it's really hard to kind of fit this into a lecture like this. But in general, there's different concepts that patients might find helpful. Some people do well with cognitive behavioral therapy, some do well with mindfulness. Sometimes when there's a component of food addiction, they might even do well with components of like a smart recovery or other addiction-based or substance use-based or behavior addiction-based therapies. So there's a lot of things that could be trialed by the patient. But when we're interacting with them, it's important to kind of ask why instead of what when they're talking about some unhealthy eating behaviors. And then also we can work with them on planning. So again, similar to the FIT prescription for exercise, with all of their other health goals, we can make sure they're SMART goals. So they're specific, measurable, achievable, relevant, and time-based. So let's get back to our patient. In conversation with you, the patient decides on the following interventions. For medications, they're going to try and decrease or discontinue the gabapentin. They're going to work with a psychiatrist on transitioning the quetiapine to a more weight-neutral option. In conversation with you, oh, sorry, that's the same thing. Nutrition, they're going to want to replace their Pop-Tart with with yogurt, with frozen berries and nuts. They want to drink a protein shake with their sandwich at lunch instead of the chips and dessert. And they want to replace 3 meals a week with a meal kit delivery. That's actually a really good option for this patient because they kind of don't have the energy to cook. So maybe we're taking already the grocery shopping out of the picture, so they can try with that meal kit to get into some like healthy cooking behaviors at home. And then they're going to, instead of snacking on candy and other snacks, they're going to try some low-fat homemade popcorn and fresh fruit. For activity, they're going to continue their current regimen, and then they're just going to add some aqua gymnastics twice a week. They're going to try not to eat any food in front of the TV to like increase mindfulness, and then they're specifically going to consume 1 meal per day mindfully by involving all 5 senses. They're going to practice stimulus control and not buy any candy or snacks in the first place. And after you've agreed on all this, you schedule a follow-up in 8 weeks, but as life goes, the patient returns 4 months later due to a busy work schedule. They report that they were able to stick with the plans for breakfast, lunch, and dinner, but find themselves craving pasta, pizza, and calorie-dense snacks whenever they are cooking their own meals with the meal kit. They've tapered gabapentin to 200 milligrams at bedtime. The quetiapine has been switched to aripiprazole. So they initially actually lost 20 pounds within the first 3 months, but the weight has remained stable since. They now weigh 259 pounds and the BMI is 38. It was 42 before. They report still struggling with back pain and limited mobility and feel that more weight loss might be helpful. And they wonder if there's anything else that can be done. So now we're going into a follow-up visit. So in the assist part here. So first we just want to assess kind of our standard metrics here. How has their weight, height, and BMI changed? Maybe the waist circumference, if we measured that before. Are they adhering to the treatment plan we've agreed on? Is there any change in their comorbidities, and what meds are they currently taking? And then there's 2 types of goals that we're looking for. The weight-based goal, and we really look for 5% weight loss at 3 months there, and that's also required by a lot of pharmaceutical companies if we are treating them with a medication. But it's also just a good way of figuring out if our goals that we've set for them are relevant, because if they're relevant, they should lead to a desired weight loss at that time. And then we're going to look at non-weight-based goals. So for this patient, for example, lowering the back pain, improving their mobility, maybe getting off of some of the medications. Reasons to adjust the treatment plan, obviously, if they don't meet those 2 goals, or if they reach a weight plateau or they regain any weight. Even moderate weight loss already has some benefits. So at 2% body weight loss, they can already have lots of different benefits. For 5%, there's even more. 10%, we even include like things like the liver disease and the obstructive sleep apnea. And then at 16%, there is actually most likely a cardiovascular and all-cause mortality improvement. So how can we further assist this patient in their health journey? Now we can get to our medical interventions. So that includes 2 different categories, pharmacotherapy and bariatric surgery. For the pharmacotherapy, I'm going to start right with the hottest topic currently, which are the GLP-1 analogs and agonists. So the liraglutide is an analog. It can lead to 8% total body weight loss. So relatively moderate, but this is the oldest one and the one that's been longest on the market. There's semaglutide, or brand name Wegovy, that can have 16% total body weight loss. Tirzepatide, or Zepbound, is the newest out, which can have up to 21% total body weight loss and is a combination of a GLP-1 and GIP agonist. I guess to those GLP-1 agonists or GLP-1 GIP agonists, it's tricky. When we're thinking about a pathophysiologic approach, these are actually the medications that modify the patient's metabolism to what's the closest to a healthy person's metabolism. So that's actually really great because they affect both the brain axis and also the GI system. So we're pretty much taking away the part that is adjusted by the patient being obese and having different metabolic processes going on that make it harder for them to lose weight. So this technically should be our gold standard, but one thing that I've mentioned before, it's used kind of as a diet drug right now, where people think they don't have to do those other pillars and don't have to adhere to a lifestyle change and can just take this medication, lose some weight, and stop it. And that's when we see all these reports about patients regaining weight, is when they suddenly stop the medication, but they haven't really adjusted to a new lifestyle. The other thing is that we're running into significant shortages due to those medications coming on the market, but also semaglutide being used, or all of them pretty much being used for diabetes at the same time. So they're running two different tracks there. And so that's what's also causing a big shortage, and patient really getting the medication maybe for the first month and then being desperate because they suddenly see how it worked and can't get it anymore. So that can also lead to a lot of trouble. So that's why there are other medications that we can use. Phentermine, as in brand name Adipex or Lamira, is an option. Very little weight loss overall, 6%. It's an norepinephrine agonist. We have bupropion naltrexone, as in the brand name Contrave, which can lead to 8% total body weight loss, so a little bit better, which has basically the two different components, although they both work in the brain through the same pathway. So they're not actually a two different component medication, even though they work in two different ways. Again, naltrexone can't be used with any opiates because it's an opiate receptor antagonist. Orlistat, which comes as Zeneca as a prescription or over-the-counter LI, can lead to 9% total body weight loss. It's a lipase inhibitor. So we can have a lot of side effects from that. Lots of people don't like it a lot because there's a lot of diarrhea, flatulence. So that can be, it can lead to incontinence, even of stool. So definitely not the most popular one amongst patients. And then the phentermine topiramate, or brand name Kisimia, can actually have the biggest weight loss, 11% total body weight loss. And this is actually a true combination medication when it comes to neuropathways, because it works on two different neuropathways, very similar to the GLP-1s. And then we can actually use those medications specific for a patient's characteristics. I just have a whole list here with different indications and ways how we can use these medications for those patients specifically. So for excessive hunger, it depends on whether they feel like they can't get full or the hunger returns too quickly. For emotional eating, low motivation change, they can use the bupropion naltrexone. That seems to work pretty well. Anxiety-induced eating or weight regain after bariatric surgery, topiramate seems to work well. And then low metabolism, again, the GLP-1s can be good with that, but if we can't use that, phentermine works pretty well. Carbohydrate cravings, we have a couple that work well for that. Food cravings in general. Mood stabilizer induced weight gain or antipsychotic induced weight gain has a couple medications that work well. And lastly, we have some from antidepressant induced weight gain. We can oftentimes add bupropion to that to augment it. Medication induced weight gain in general, we have some options there with GLP-1s, naltrexone. And then obviously if they have comorbidities that would potentially benefit you, we could use, for example, topiramate in a patient that also has insomnia or migraines, or bupropion or phentermine, a patient that also has low energy or motivation. Then we have one kind of in-between option, which is a non-surgical medical device, which is Plenity. This is can lead to 6% of total body weight loss, and it's a cellulose and citric acid hydrogel capsule. So they basically take it, it expands in the stomach, and then they kind of get full quicker and and not as hungry as quickly. And then we have our big option of bariatric surgery, which there were old guidelines or from the 1991 consensus that actually said cutoffs were BMI of greater than 40 or 35 if they have one comorbidity. But there was recently, actually in 2022, a change by the American Society of Metabolic and Bariatric Surgery where they actually lowered those thresholds to BMI of 35. And they also included those Asian patients with a lower threshold of 27.5. And then also they included 2 additional categories, BMI of greater than 30 with type 2 diabetes or adjusted for Asian patients, 25, and then BMI of 30 without substantial or durable weight loss or comorbidity improvement. So now we even have an inclusion for anyone with obesity who is not getting better with other measures. There are contraindications, uncontrolled mood disorder, psychosis, uncontrolled eating disorders, substance use. If they're not able to comply with the nutritional requirements, like even just multivitamins, but also just the low calorie, low food plan. If they're pregnant or planning to be pregnant soon, and then all kinds of regular surgical contraindication, like cardiac pulmonary disease, coagulopathy. Of note, there's no upper age limit that they noted, so that's interesting. And then the different types, there's Roux-en-Y, which is pretty much the most popular one. It has a very good weight loss, just so you don't get shocked with the higher numbers there. That's excess body weight loss, not total. So this is different from our medications. That's what the surgeons have been using forever. So they're looking at the numbers a little bit differently. And then the vertical sleeve gastrectomy is pretty similar, maybe slightly less effective, but has potentially some lower complication rates from nutrient deficiencies and things like that. Then there is still the gastric band, which is still used occasionally, but a lot of patients are having this removed actually. And then we have our really new option of the endoscopic sleeve gastroplasty, and that can be done all endoscopically. It's not technically a surgery. The patient is just getting basically staples on the inside, or not staples, but sutures on the inside of the stomach to lower the volume. And so that can be, that's something that we can now consider for patients who maybe are not surgical candidates, but still would benefit from a bariatric intervention. Currently not, at least in our region, not covered by insurance. So it's like a $12,000 out-of-pocket cost, which the bariatric surgeons argue is obviously an investment if you're thinking of the cost of GLP-1s over a long time, but on the other hand, it's obviously still a lot to afford. So let's get back to our patient. We counsel them about the options, and they tell us that they would like to go with pharmacological options rather than surgery. So we have to think about what could be a potential good medication for this patient. They have antipsychotics, mood stabilizer related weight gain, so maybe GLP-1, metformin, topiramate. They have some carb cravings, so topiramate, phentermine, spironolactone might be good. They have low energy, so if possible, we could use bupropion or phentermine. And then there's some things to think about to avoid: naltrexone because they take tramadol, phentermine because they have a history of cocaine use, and then technically bupropion we would probably want to avoid unless we want to discuss this with the psychiatrist since the patient is on some medications already. So from that, we kind of end up with maybe a GLP-1, or we could do topiramate and or metformin. So we end up prescribing semaglutide, but then this is not covered by insurance. Tirzepatide isn't either. The patient actually called the insurance, and the insurance told them that no weight loss medications are covered at all. We could also just replace the scenario by it is covered, but it's not available. So we have to come up with an alternative plan. So we start metformin, tell them to increase it to 1,000 BID. We start topiramate, 25, tell them to increase it to 50 milligrams BID if possible, or if needed to control the cravings. And then we set some additional SMART goals for nutrition and activity. So now the patient tolerates the medication well, follows up very regularly. 7 months later, their weight is down by an additional 35 pounds and the BMI is now 33. They report improvement in their back pain, and they were able to wean off gabapentin completely and use tramadol very rarely as needed. Repeat labs are stable, except now the LDL is 98 and the HDL is 52. They ask if they need to change medications further because they see that their BMI is still over 30, so they wonder if they need to get it to normal range. So our answer is no, they've reached their non-weight-based goals. They've improved their back pain, improved the dyslipidemia. They've also actually reached their weight loss goals, maybe just not for the total body weight or BMI. So at this point, we can just use shared decision making and tell the patient that we could determine further steps together. You could intensify the lifestyle measures and see if you can lose a little additional weight. We could change your medications and see if a different combination would get you some increased weight loss. Or we could just continue the current approach since you're doing well, you've lost some weight, you're healthier now, you're functionally doing better. So we really don't have to do anything. So some take-home points here. Again, obesity is a chronic, relapsing, and treatable disease. BMI is the best screening tool. Waist circumference, in addition, can be helpful in those borderline BMIs. Definitely consider the ethnic differences and use the appropriate cutoffs. Try to reduce the weight stigma in your office, train your staff, do your best to reduce weight stigma in your interaction with the patients. Use the 5 A's to guide your management approach. Remember all the 4 pillars of treatment. And then there's no one size fits all in treatment. So really find an individualized plan that works for your patient. And then focus on the non-weight-based goals. And remember that even moderate weight loss improves the patient's health. And this should be our main goal. And so I'm going to end this with the goal of obesity medicine and a quote from Scott Cahan. Obesity medicine goes beyond the number on the scale to understand, support, and treat the whole person. Simply focusing on weight or weight loss may have unintended consequences, such as not appreciating the health benefits of moderate weight loss or not appreciating the benefits of positive health behavior changes that don't show up on the scale. And I think that fits very well with our values at Creighton with Cura Personalis. And so I think we should all try and keep that in mind. Yes.
Contribute a whole lot to the actual weight loss itself, but there maybe is a replacement of the skeletal muscle, and that might be encouraging to the patient.
Yeah, absolutely. So those impedance analysis scales, I think, are a really good investment if possible to have those in your office and kind of get an initial assessment when you start the plan with the patient and then kind of monitor this occasionally over time, because it could really help figure out if they're making progress that might not show up on the scale. So I definitely think it's a good idea. I think it's not going to be possible to have those in every office, but sometimes patient can get actually their readings done maybe at a gym or something like that. So if you have access to this, I think it's really good for like treatment progress monitoring. It's not very well correlated with cardiovascular mortality or morbidity. Yeah.
How do you order? Do you use a DEXA scan for this, or how do you order one?
So I actually don't use a DEXA scan. I think it's more so in like research studies is when you would use the DEXA scan to really have an accurate assessment. Where I would consider using a DEXA scan would be if I had an elderly patient where I'm suspecting sarcopenic obesity and I want to maybe use an obesity medication or weight loss medication, but they don't maybe meet the diagnostic criteria. So I could diagnose it based on their body fat percentage. But then I don't know how we would communicate that with the radiology department, because I feel like if we just order a DEXA scan, they would just read it as a bone density like DEXA scan and not as like a body composition analysis. So it would probably need like a call to radiology to order that specifically.
Good question. So for the medication that help with weight loss, each medication having its own like percentage weight loss. If you use 2 or like more, is the percentage like do they add up?
It's not a complete addition, but sometimes it can add an additional effect. So let's say if you have a patient with PCOS and initially you're starting them on metformin just to see if you can help with their metabolism. And then later on you figure out, well, they've lost a little bit of weight, but they're still maybe struggling with cravings or other behavioral problems. You could add one of those other medications that have more behavioral effects or affect the brain axis a little bit more. And that could add to their weight loss actually.
How do you counsel patients come to you only asking for GLP-1?
then I draw the 4 pillars and I say there are 4 pillars and we have to first make sure we get the first 3 right, and then we can think about the 4th.
But is there anything else we can offer just to kind of get there for us? Because I've seen a couple who are like PCP shopping or even going between specialties, being like, hey, I just need to get some of that.
Yeah.
So I don't know how to help them.
I agree. I think we're not going to be able to keep all of these in our panel. If they really are set in their decision, they might go to even a med spa and get one of those compounded semaglutides that we don't know if there's even any efficacy with those. They're definitely not regulated in any way. But I try to make sure they understand the concept of long-term weight loss and how to sustain that, and that this is more than just getting this medication. And I try to invite them to work with me to like figure out what a good plan for them could look like in the long term. So that's all we can do.
Are you seeing any decrease in referrals to bariatric surgery? And do you envision any change in bariatric surgery guidelines to use medications first?
So I think the bariatric surgeons still are very convinced that actually the bariatric surgery should be the first approach. I think there's some studies on showing that some of the interventions are less effective after the patient's already maxed out their weight loss on medications. So then they might either not have any additional benefit when they then maybe go on to have surgery, or maybe they've lowered their BMI to a threshold where they wouldn't qualify anymore, or won't meet those criteria anymore. So I think from their end, they're still hoping to catch more patients initially before they even start on medication or pharmacotherapy treated for obesity. So I think they try to catch them earlier than that for those reasons. But I think since there's a lot of good options now medication-wise, and I feel more comfortable to use them, I try to first figure out my patient's goals. So if a patient's goal is, I want to be off of as many medications as possible, I want to take as few medications as possible, then I explain to them that most of the time, if they're going to start on a weight loss medication, there are chances that they might stay on that medication or some other medications at least to control their chronic comorbidities in the long term. But if their goal is to really be off of as many medications as possible, maybe bariatric surgery is the right direction, because this is the only thing that's really sustainable. If they stick with their nutritional plan and their other lifestyle changes, then really there's a good chance they could lower doses of their blood pressure meds, of their diabetes medications, maybe get off of all medications for weight loss specifically too. So I kind of try to figure out what their goal is and then decide what pathway is the best for them.
So I saw you still have phentermine as a medication for obesity, but given that we have a lot safer medicines now, should we even have that, potentially dangerous medicine on the formulary?
Yeah, so looking kind of at long-term data, it actually is relatively safe. The FDA has only approved it for 12 weeks though. So if you want to stick with FDA recommendations, you actually have to use it for 12 weeks and then discontinue it. And you should obviously counsel the patient that that's what the FDA approval is for. There are possibilities of continuing it if you document very well, or maybe even have the patient sign a waiver and say, we're using this off-label, so you're agreeing to potential side effects because we don't know what the long-term effects of this medication are. And also there's a potential of developing tolerance to the stimulant. So it is something to weigh the risk benefits really carefully and make sure the patient is aware of that. But I do think in some patients it still has its role, especially with the shortages of the GLP-1s and insurance not covering them. In some patients that can be a good option.
What the percentage of acute kidney injury after starting pharmacological treatment?
That's a good question. I don't know the exact percentage. I think most of the time it's related to GLP-1s, for example, causing decreased appetite. And in our brain, the center that controls appetite and thirst is the same. So oftentimes patient can't identify whether they're actually hungry or thirsty. So a lot of times when they're taking the GLP-1s, both thirst and hunger go down, and they might just not hydrate well. So then they might end up with acute kidney injury from dehydration. So I just counsel the patients about that and say, you might not be as thirsty, make sure you track your fluid intake and make sure you drink enough during the day. Or if they're at risk for it, I might decide to do a creatinine check after a couple weeks after they've started to make sure that they're hydrating enough.
Any questions on Zoom?
Thank you for a wonderful, comprehensive talk. How often are you seeing these patients? Because these are long conversations. And this is like, I mean, I'm thinking just even for an annual physical, if you start talking about this, there goes your half hour.
Yeah.
Really quickly, you know.
Hour.
Yeah.
Yeah. It depends a lot on the patient and their needs. I will say sometimes I have patients that come for an annual physical, and then this is their only other concern. And then I'm sometimes able to at least get a conversation started during that visit. Other times, if I don't have the time, I'll tell them that, do you want to come back to discuss this in more detail? And then depending on my schedule, that might be in 4 weeks or 8 weeks. It can be a little wait until then, but then I try to give them almost like some homework in the meantime, or develop a plan with them in the meantime, things that they can try until then, so we can kind of look at those results. And even if it's just that I give them a handout on like their weight history, so they can really reflect and go into all the details of when they started gaining weight and what the triggers were and what their behaviors around food are like, just so we have something to talk about the next time they come in. So oftentimes I will bring patients in for a 30-minute visit for weight management. The important thing with that is that it's not covered by insurance to bill this under the obesity diagnosis, but rather the associated comorbidities. So let's say the patient has dyslipidemia and hypertension, then I can talk with them for a 30-minute visit about their obesity, because those are going to affect those two conditions, and I'm going to note those in the chart and say that we're doing lifestyle measures for those two conditions. So that's a way to get more time to talk.